Good day and welcome to this webinar on how can health economics help us to optimize osteoporosis management. My name is Dominique Pierrot. I'm the science manager at IOF and I'm delighted to moderate this webinar. Before introducing the speaker of the day, I would like to inform you that attendees are automatically muted. I also would like to encourage you to ask questions during the webinar by typing them in the Q&A box, and I will voice them to the speaker toward the end of this webinar. This being said, I have the great pleasure today to welcome Professor Mickaël Hiligsmann, who is Associate Professor in Health Economics and Health Technology Assessment at Maastricht University in the Netherlands. Professor Hiligsmann is a member of the IOF Committee of Scientific Advisors, of the IOF Epidemiology Quality of Life Working Group, and captures a Fracture Partnership Policy Steering Committee. He is also a member of the Scientific Advisory Board of SKO. Dr. Hiligsmann is a recipient of the 2018 SKO Medal of Excellence and has more than 250 publications in international peer-reviewed journals. He is a member of the editorial board of several peer-reviewed journals, including Osteoporosis International and Aging Clinical and Experimental Research. His main research interests include health technology assessment, cost-effectiveness analysis, evaluation of healthcare, patient involvement and preferences, with a strong interest and experience in musculoskeletal diseases such as osteoporosis. Professor Hiligsmann, thanks again for having agreed today to present this webinar, and we are now listening to your presentation.
Many thanks for your complete and kind introduction. It's a real pleasure and an honor for me to give this webinar on how can health economics help us to optimize osteoporosis management. And first of all, the key learning objective of the seminar first is to provide a general overview of health technology assessment and health economics, and also about the relevance of health economics in healthcare policy making. Also to present what are the roles of health economic evaluation, and especially in the context of osteoporosis. And I will finally also review some recent economic evaluation and their key messages on therapeutic option and prevention program, and provide some recommendation for osteoporosis-specific health economic evaluation studies. But first, I will start with the rationale, the roles, and the definition of health economics, of economic evaluation. And first of all, why health economics? Why is health economics becoming so important? It's because we have a tension, an increasing tension between a rising demand of healthcare, we have unlimited needs, and budget constraints, we have scarce resources. As you can see on this figure, in 2015, the health expenditure in the Netherlands were estimated at 80 million euro, and they are expected to substantially increase in the future, to probably double in the next 25 years. And this is due to the increasing in life expectancy, but only partially, and mainly to new technologies, to new medical technological possibilities that are more expensive. In this context, the policymakers need to make some choices, because if they use more money for healthcare, they have less money for education, for infrastructure. Because in this context, it's really important to efficiently allocate the scarce resources. And this efficiency is becoming really important. The importance of health economics to help policymakers to efficiently allocate healthcare resources is especially important in the context of osteoporosis for different reasons. First, because osteoporosis is a major public health problem. The Scope 21 IOF project, a new scorecard for osteoporosis, in EU 27 countries and Switzerland and UK, revealed the huge cost burden for osteoporosis-related healthcare. In this country, 32 million of people have osteoporosis in 2019, leading to more than 4 million of fractures for a cost of more than 56 billion of euros. This osteoporosis is a major public health program, and then we need to efficiently allocate resources for osteoporosis. Furthermore, osteoporosis is a problem on the rise. In the same Scope 21 project, the number of adults over 75 years is expected to increase by more than 40% in men and by about 30% in women, leading to a substantial increase in the number of fragility fractures. It is estimated to increase by about 25% in the next 15 years. And the increasing incidence of fragility fracture is even higher in non-European countries. For example, in Asian countries or in other parts of the world, the incidence is really increasing. This with an increasing burden, we really need to efficiently allocate scarce resources. Furthermore, we have a huge treatment gap in osteoporosis, and the treatment gap is defined as the difference between the person that are eligible for treatment and then patients that effectively receive a treatment. The treatment gap was estimated in 2000 at 55%, and in the Scope 21 project at 71%, meaning that about 50 million of European women at high risk remain untreated. So we really need solutions to improve the efficiency of resources in osteoporosis. Thus, we have then some needs. We need to efficiently allocate scarce healthcare resources. We need solutions for fracture prevention to reduce the burden and the increasing burden of osteoporosis. And we need to convince policymakers about the value and the economic value in particular of osteoporosis management. In this context, health economics is key because health economics aims to efficiently allocate scarce resources, could provide cost-effective solutions for fracture prevention, and could help to convince policymakers about the value of osteoporosis management. For payers, there are different requirements that are important for any health technology. The new health intervention should have a good value and should be affordable. And regarding the value of any health technology, it should be a good clinical value and it should be a good economic value. A good clinical value, answering the question, how much better does the innovation perform compared to standard of care? This is mainly looking at the efficacy and safety of the health technologies, but economic consideration is also important. We need health intervention with a good economic value. Is the added value of the innovation worth its price? We really look at the value for money. And then the affordability is also another important consideration for payer. And that's estimated with a budget impact analysis. Thus, the payer has the budget to pay the innovation. With this consideration, clinical, economic value, and affordability are important in all of the countries, with maybe a few differences in the importance given to some of these criteria. For example, in the UK, economic value is really important and it's maybe a bit less important in some other countries. The budget impact is especially important in countries like Spain or Italy. But in all of the countries, good clinical and economic value and affordability is important for payers. With some example of policy questions linked with health economics. Is it worth to invest money to tackle osteoporosis? Are osteoporosis medication effective and cost-effective? Are fracture liaison services an efficient way of allocating scarce resources? And to answer this question that are really important for policymakers, economic considerations are important. We need to look at clinical dimension, the clinical effectiveness, the safety to answer this question, but also at the economic side, because we really need to look at the value for money and the affordability of health intervention. And this logic of safety, clinical effectiveness, and economics come together in what we call the HTA, the Health Technology Assessment. And on this slide, you have a definition of HTA defined as a multidisciplinary process that uses explicit methods to determine the value of a health technology at different points in its life cycle. And the purpose of HTA is to inform decision-making to promote an equitable, efficient, and high-quality health system. Because within HTA, we look at different dimensions, including clinical effectiveness, safety, but also the cost and economic implication. And some other dimension could also be important depending on the disease and the intervention. HTA is becoming more and more important in an increasing number of countries. On this slide, you see the HTA activity in European countries, and in the yellow countries, you see that we have an HTA agency for both pharmaceuticals and non-pharmaceuticals. And even in countries from other parts of the world, we really see an increasing number of HTA agency and HTA activities. The role of health economics is thus becoming increasingly important, in particular in the drug reimbursement and pricing process. If a pharmaceutical company would like to get a reimbursement and a price, in many countries, the industry has to include an economic evaluation showing that the drug is cost-effective. But also for public health programs, we see an increasing interest and increasing use of health economics alongside medical consideration. We also see an increased use of health economics to help the value-based pricing of experimental technologies. We start the process of health economics really early in the research and development process of a new technologies, also to identify what could be a possible price, a good value-based price in the future. And we also observe that funding agencies also require more and more economic studies being conducted alongside clinical studies. But what is an economic evaluation? An economic evaluation looks at the cost and the effect of healthcare intervention. So with an economic evaluation, we have a framework to identify and to compare the cost and the effect or the benefits of options to really inform policymakers about an efficient healthcare allocation. This slide provides us a nice illustration of this definition. In an economic evaluation, we compare at least two health technologies. It could be a new device versus the old situation, could be drug A versus drug B, but at least two interventions in two dimensions. We look in cost, and we look at the effect, the health outcome of the intervention. And the economic evaluation will look at the relationship between the difference in the cost and the difference in the effect measured in quality that will be explained in a few minutes. So an economic evaluation, comparison of cost and health outcome of at least two interventions. There are different cost types that we could include in an economic evaluation or not. They are classified into medical costs, such as the cost for GP visit, cost of hospitalization, or the cost of medication, to the patient and family costs, the out-of-pocket payment, also the travel expenses, but also the productivity losses, the inability to work because of a disease, or the reduced productivity at work. And the costs that are included in an economic evaluation depends on the perspective of your economic evaluation. If we include all cost types, we have a societal perspective, recommended in some countries. In other countries, we only include the healthcare cost to have the healthcare perspective. So we have the cost, and then we have the outcome. Two ways to measure the outcome of an economic evaluation. We can look at the clinical outcome, which is typically fractures that we get from trial, but we more commonly use quality of life measure with patient-reported outcome. And quality of life are nowadays increasingly measured within these health-related quality of life studies. Most guidelines for economic evaluation recommends the use of quality-adjusted life years as the outcome, the QALY. And one QALY is 1 year in perfect health. So in a QALY, we combine the length of life, the life years, and the quality of life. And the quality of life is measured by the utility. The utility is a score, a number between 0 and 1, when 0 corresponds to the worst health state and 1 corresponds to the best possible health state. And we use QALY because QALY can be used for any disease and any intervention. Thus we can really compare between diseases. QALY is also sensitive to multiple aspects of treatment because we can capture the morbidity gain, but also the mortality. And QALY is nowadays recommended as the standard for economic evaluation. QALY is, however, insensitive to small changes in some diseases, but is still the standard. To measure QALY, then we combine the life years and the utilities. So here you have an example. We have the life years and we have the quality of life measured between 0 and 1. And the QALY is the area under the curve. This is an example of a profile without an intervention. And if we get an intervention that improves the quality of life, that also improves the life years, we get a gain in QALY measured here in blue. So the gain in QALY is the differences between the two areas under the curve. To measure the utility, the score between 0 and 1, we typically use an instrument like the EQ5D. We can also use the SF36. The EQ5D is a simple 5 health dimension questionnaire, and each dimension, mobility, self-care, usual activities, pain, discomfort, anxiety, depression, have 5 possible levels. And thus we ask the patient to select one level for each dimension. For example, this patient mentioned, I have no problem in walking about, I have slight problem watching or dressing myself, I have no problem doing my usual activities, I have no pain or discomfort, and I am slightly anxious or depressed. This will give you a profile 1, 2, 1, 1, 2, and the profile is associated to a utility score with a valuation set that is available in most of the countries. Regarding the costs and utilities of fractures, we know that fractures lead to substantial costs, especially for hip fracture, and costs in the short term, but also in the long term. Fractures also lead to an excess mortality, especially for hip and clinical vertebral fractures. Fractures also lead to a decrease in quality of life. One famous study regarding the costs and utilities of osteoporosis fracture is the IOF-ECURA studies. It was a multinational observational studies that aimed to describe the cost and quality of life consequences of osteoporotic fracture in 11 countries and in more than 500 patients for a period up to 18 months following the fracture. To non-economic evaluation, if you remember this figure, we compare the cost and the health outcome in QALY of 2 interventions. The outcome of the economic evaluation will be presented in incremental cost-effectiveness ratio. And the incremental cost-effectiveness ratio, the ICER, will use the cost and the effect of both interventions. Because the ICER is defined as the difference in the cost between the 2 interventions divided by the difference in the effect, by the difference in the QALY. And the ICER represents the additional cost per extra unit of effect from the comparator treatment. Thus we get the additional cost of the intervention per QALY gain, the additional cost per 1 year in perfect health. And the lower the incremental cost effectiveness ratio, the lower the additional cost of the intervention, and then the more cost effective the intervention is. And an intervention is considered cost effective and should be adopted from an economic point of view if the ICER is below a certain threshold that represents the willingness to pay of decision maker. And the willingness to pay of decision maker is about 2 times the gross domestic product of the country, or in the US, in the range of $100,000 US to $150,000 US. The result of the economic evaluation can also be presented on the cost effectiveness plan, where we have the comparator treatment at the origin, the effect differences, the quality difference of the X gain, and the cost difference on the Y axis. The best possible situation is to be located here, having a new intervention with more effect, more quality, more years in perfect health for less cost. And remember that the costs are the total cost. It's not only the cost of the intervention, but it's also the safe healthcare costs that we could prevent with diseases. And in this situation, we speak of dominance. And that's, by example, the case of osteoporosis treatment in patients aged over 80 years, when we see that the saving cost from treating this patient is higher than the cost of treatment. An intervention associated with more quality and more cost, if they are below the threshold, they should also be adopted from an economic point of view. Regarding the methods for economic evaluation, I will not explain them in detail because otherwise I would need a few hours to do it, but just a few information to explain you how does it work. And first of all, a trial is not sufficient to capture all of the benefits, costs, and consequences of fracture prevention. Because if we prevent a fracture, we will have benefit not only during the trial, but we will have benefit over the long term, because preventing a fracture could reduce the cost in the future, could also improve the quality of life, and could also lead to some additional life years. So we really need, in an economic evaluation, to capture all of the benefits and cost of fracture prevention. And that's why we need to use some techniques, some modeling techniques, to really predict the long-term consequences of fracture prevention. And thus we use economic model to predict the health outcome and the cost consequences beyond the duration of the trial, beyond the scope of available evidence. And we also need models to compare interventions that are not directly compared in trial. So we often use indirect comparison in economic model. And we also use economic model to generalize results to other settings or patient groups. And in this figure, you see typically an example of an economic model where we will simulate the number of fractures we get in the population. Thus, we typically start with no fracture at the current state, and patient would get a hip fracture, a vertebral fracture, or non-hip, non-vertebral could die during the process. Alongside economic evaluation, budget impact analysis can also be really important to assess the affordability. And budget impact analysis are also increasingly required in traditional HTA along with cost effectiveness analysis. And you have on this slide a long definition, a lot of explanation of budget impact analysis, but you will receive the slide anyway after the presentation. But the budget impact analysis will estimate the likely change in expenditure. Thus we use a budget impact model, typically over a period of 3 to 5 years to really assess the affordability of an intervention. And typically, we have the current environment, the total population, the target population, the cost of illness, and we assess the impact of a new intervention that will potentially affect the target population, affect the resources, and leading to a new cost of illness. And the differences between the new situation and the old situation will lead to the budget impact. Now I will present the main findings from economic evaluation in the field of osteoporosis, including several systematic reviews. And first, an updated systematic review of cost-effectiveness analysis of drugs for osteoporosis in women published in 2021. This review identified 27 articles in 15 countries using 12 active comparators, but also some sequential therapy. What are the main messages? First, anti-osteoporosis medication are cost-effective in women in most studies in women aged over 60 to 65 years with low bone mass, and especially women with previous fracture. We also observe a dominance in women aged 80 years and over. As explained before, dominance means that the safe costs due to the effectiveness of the fracture are higher than the cost of treatment. Active agents such as abaloparatide, romosozumab, or denosumab, or other form of oral alendronate are generally cost-effective or dominant compared to traditional oral bisphosphonate. It is, however, difficult to make clear recommendation between drugs due to also overlapping confidence intervals. A very recent paper accepted for publication in Osteoporosis International, but not yet published, did a systematic review of cost-effectiveness analysis of sequential treatment for osteoporosis, and 10 articles were identified. And based on this review, the author concluded the better health outcome with sequential therapies compared to monotherapies, but also in more than 75% of studies that sequential therapy with an anabolic first, such as abaloparatide or romosozumab, followed by an anti-resorptive, is cost-effective or even dominant compared to bisphosphonate monotherapy, especially in a high-risk population, because the drug acquisition cost is also a driver. With a large group of experts, we also recently get a paper entitled Cost-Effectiveness Analysis of Intervention for Osteoporosis in Men, systematic literature review accepted for publication in Pharmacoeconomics. The proofs have been reviewed and the paper will be available in the next few days. 25 articles were identified and were about drugs and nutrition, intervention threshold, screening, post-fracture care program. And this review concludes also the cost-effectiveness of anti-osteoporosis drugs and nutrition supplement in men with osteoporosis. Also conclude the economic benefit of screening strategies and post-fracture care programs for men. In general, the cost-effectiveness and the intervention threshold were rather similar in studies conducted in both men and women, because the studies also included studies comparing men and women, with maybe slightly greater incremental cost-effectiveness ratio in men. Another systematic review published 3 to 4 years ago in Osteoporosis International reviewed the cost-effectiveness analysis of fracture liaison services. And at that time, 33 articles were identified. And it was shown that FLS was cost-effective compared to usual care or treatment, regardless of the program intensity or the country. And the dominance, this meaning more quality for less cost, was shown in the majority of the study, suggesting the high economic value of FLS. Other health economics analysis has been conducted, by example, to derive intervention threshold. For example, on this slide, the famous figure from John Kennis showing the risk of major fractures and of hip fracture at which it is cost-effective to treat osteoporotic patients. With health economic assessment have been used to determine at which fracture risk it is cost-effective to treat patients. In another work with Manju Chandran as first author, we also look at the cost-effectiveness of FRAX-based intervention threshold to assess if FRAX-based thresholds are cost-effective or not. There's a lot of application of cost-effectiveness analysis in the field of osteoporosis. 2 other applications. The first one is the long-term cost-effectiveness of screening for fracture risk in the UK primary care setting. And these studies also show the dominance, the cost saving of screening for fracture risk. The screening leads to lower total cost for more quality compared to the usual management. In another work, the cost-effectiveness of using patient decision aids was also shown to guide osteoporosis treatment. There's a lot of application of cost-effectiveness, and a lot of them really suggest the high economic value of osteoporosis medication in both women and men. Also suggest the dominance, especially in those aged 80 years and over. Also suggest that sequential therapy with anabolic and anti-resorptive is a good way to allocate healthcare resources. Also suggests the high economic value of post-fracture care program, and that intervention threshold are cost-effective. Thus, we have good economic arguments to convince policymakers about the high economic value of osteoporosis management. Another example of economic studies is from the Capture the Fracture partnership. And as part of this partnership, different country-specific reports are built up and include a budget calculator. The budget calculator has been designed by Rafa Pinedo Villanueva from the Oxford team, and they estimated what could be the benefit of implementing fracture liaison services in different countries. And in this example for Spain, if we include fracture liaison services, we could expect to avoid more than 3,500 fractures in the next 5 years. This will lead to a reduction in hospitalization and societal costs for different aspects of hospitalization, leading to a saving of about 30 million euro. This fracture avoided will also lead to an improvement in patient health, more than 4,000 quality gain, more than 4,000 years in perfect health. But we also know that fracture liaison services will require some medical staff, but only 1.6% of the total cost we currently spend on the burden of fracture, and it's just a minor proportion, but it's for a total of 164 million. Because the total cost of FLS in Spain would be 135 million, but when we put the cost and the quality together, we have something that is highly cost effective. And this Capture the Fracture partnership with this policy report also provides information on the yearly cost we could get from the budget impact and the quality gain per year. How to conduct an economic evaluation? This, as previously mentioned, we need a simulation model that will include a lot of data, incidence data regarding the number of fractures, and especially in a specific population, fracture cost, also fracture impact on the quality of life, excess mortality, treatment effect, and we conduct the analysis and sensitivity analysis. It's not an easy task to build up an economic model, and to help researchers to conduct economic evaluation, a working group from SKO and the IOF was set up 2 or 3 years ago to provide recommendations for the conduct of economic evaluation in osteoporosis. And this includes a lot of recommendations regarding different aspects of the economic evaluation in osteoporosis. Within this document, recommendations for the design and conduct of economic evaluation, but also for the reporting of economic evaluation. And the aim of this guideline is to improve the transparency, the quality, and the comparability of economic evaluation in osteoporosis. Because it's important to promote high quality economic evaluation to really increase the use by decision maker and to lead to a more effective allocation of resources. But there are still some challenges of economic evaluation in osteoporosis. First, there are some differences in fracture risk and comparator in cost between countries, that we often need to conduct national studies, national economic evaluation to really reflect the specificities of the countries. Another potential challenge is the lack of head-to-head comparison between drugs. And we typically use network meta-analysis in some economic evaluation. The quality of model structure and the good reporting is also something really important so that the policymaker could trust the economic evaluation. Then it's really important to develop a good economic model with good data and to follow guidelines. Just 2-3 slides to conclude my talk today. But first, the new development in health economics. Health economics is a field of research becoming more and more important, but also characterized by new development. For example, real-world data, real-world evidence provides new information that could be really important to increase the reliability of health economics. And an SKO working group has been set up and a non-sponsored symposium will be organized at WCO in Barcelona. As part of health economics, we also see an increasing interest to investigate patient preferences and values. We also observe that early health economics is becoming increasingly important, that we do not only conduct health economics for pharmaceutical reimbursement decision, but we really start early in the process to really investigate what could be the potential benefit of intervention. And finally, we also observed that in the field of HTA, that there are new elements of value that are becoming also important for a payer. It's not only the dimensions of quality and cost, but the effect on productivity, on informal caregiver, on adherence, improving factor, and a lot of other considerations are also becoming important to really put the place on a good value for medicine. Key message: health economics is unavoidable because scarcity is unavoidable. But we must not focus narrowly on the cost of the intervention, but really on the cost effectiveness, on the economic value of health intervention. So it is important to take economic argument into consideration in decision making, in clinical decision making, but also in policy decision making. We have strong argument in osteoporosis, strong economic value of different intervention to improve the management of osteoporosis. And the last slide is 2 additional resources. At Maastricht University, with one of my PhD students, we designed a self-learning course on health technology assessment and economic evaluation. Because if you would like to learn a bit more regarding economic evaluation and HTA, I really encourage you to go to this self-learning free courses. And I also invite you to have a look at the Capture the Fracture Partnership Policy Group, where we provide some solutions for fracture prevention. And the reports are available for Italy and Spain, and additional reports will become available in the next few weeks and months. And a non-sponsored symposium will also be provided during the WCO SKO Congress in Barcelona. I thank you for your attention.
Thank you very much, Professor Hiligsmann, for this clear presentation. I think it was greatly appreciated by our audience. I can see, for example, from the Q&A that Professor Dinser is thanking you for your excellent presentation. I think it's now time to move on to questions. And maybe I will start with this question while people are still typing their question. So what are the main challenges in conducting economic evaluation in men compared to women, I suppose?
Yeah, thank you for your question. And in the review that has recently been accepted, we see that the number of economic evaluation in men is still low compared to economic evaluation in women, because we miss also some data. And we need good data to build up an economic evaluation. But with the increasing awareness of the burden of men, that could certainly not be underestimated, because probably 1/3 to 1/4 of the fracture are happening in men, we need to conduct more and more economic evaluation. And the challenges could be to get also more data. Also, we miss some anti-fracture data. But more drugs in men, they are also accepted. They are entering the market because they have similarities in bone mineral density gain compared to women. And this has been accepted by regulatory and also by HTA agency, and can thus also be used in economic evaluations.
Thank you. Dr. Bele is asking, how do you see the experience of HTA application in low and middle income countries?
Yeah, that's also a very interesting question, because HTA has a very long tradition in high-income countries, but we also see nowadays an increasing interest in low and middle-income countries, but also some more challenges, because it's even difficult to get some data, even regarding the incidence of fracture, the cost of fracture, that could also substantially differ from the data we have in high-income country. But I would really encourage also people from low and middle-income countries to collect more and more data regarding the burden of osteoporosis, to really show that it's an increasing burden. And with this data, we would be more able to also conduct some economic evaluation in the field, because the HTA appraisal is really becoming more and more important in low and middle income countries. As we could really expect that in the next few years, this type of economic evaluation that are mandatory in high-income countries will maybe also be mandatory in low and middle-income countries. But we all need also the clinician and the researcher to try to collect as more as data possible regarding the burden of osteoporosis in these countries.
Thank you. Dr. Lanske is asking, is mentioning that head-to-head studies in fracture risk reduction are now possible, but which databases do you believe has the most robust data sources?
Yeah, I think we commonly use network meta-analysis. In the future, also with the development of real-world data, it would be interesting to have large database, but the quality will also be important. We need good quality. Database that could allow us to really compare the real-life effectiveness in drug. Because currently in most economic evaluation, we use drug efficacy data, but what we really would like to assess is the cost effectiveness. It's really the effectiveness in the real-life setting. Because I think we have also, as I mentioned in the presentation, an SKO working group working on recommendations for real-world evidence in the field of osteoporosis. And the result of the working group that took place in December will be presented in a non-sponsored symposium in Barcelona. So I really invite people to join also what could be the recommendation for real-world data in the field of osteoporosis.
Thank you. Now there is a question from Dr. Hatch. Is wondering what non-pharmaceutical intervention are being considered. Are you open to doing research on the impact of isometric exercise, resistance training as an effective approach?
I think in economic evaluation, we can do any health technology. In the definition of HTA, it's just health technologies is anything that could help the health of a patient. Because we do a lot of economic evaluation for drugs because it's mandatory, but we can do it for any type of intervention, including non-pharmacological intervention. Think of the condition to conduct an economic evaluation is to have some effectiveness data. And if we have an intervention that leads to, that is more effective than another intervention, and that can also be for an exercise program, then it could be worthwhile to also look at the next step, look at the cost effectiveness to see if probably the additional costs of the exercise program are worth the additional health outcome, the additional benefit we could receive from the intervention.
Thank you. Maybe another question. What could be you already tackled a bit this topic, but what could be the value of real world data for health economic?
Yes, as I previously mentioned, we typically use efficacy data in economic evaluation, and we try to include medication adherence in the model because we know that patients are not fully adherent, and adherence has an impact on the efficacy, because we try to model like this the real-world cost effectiveness. But if in the future we really have efficacy, real-world effectiveness data, then that could only reinforce the quality and the reliability of economic evaluation. Because then we really use directly real-world effectiveness data. So I think this really open further research for cost-effectiveness analysis in the field of osteoporosis.
Thank you. Dr. Kranke is asking if HTA are appropriate for software that could be used to streamline the operation of a fraction liaison service.
I said, why not? As I said, any health intervention could be potentially assessed if there were a lot of economic evaluation comparing FLS to non-FLS, but we could also imagine to conduct one economic evaluation of optimizing FLS with maybe a specific software compared to FLS as usual care without the specific software. With everything, we can really do a lot of economic evaluation. Of course, we need data regarding the effect of using the software, but if such data are available, it could be possible to build up an economic evaluation.
Thank you. Dr. Bellet is asking if you could further comment, I think, on the difference versus a the difference between a trial versus a model-based economic evaluation.
Yeah, just to conduct an economic evaluation, we have two main methods. We have a trial-based economic evaluation or a model-based economic evaluation. In a trial-based economic evaluation, we collect the cost and quality alongside the trial. This method is sometimes used in several diseases when all of the costs and consequences captured during the duration of the trial. But in osteoporosis, if you prevent a fracture, you will get additional benefits in terms of life years, quality of life, and reduced costs that will also be after the trial. Because a trial-based economic evaluation will never capture all the costs and all of the consequences of the intervention. But that's also why a trial-based economic evaluation is not commonly used in the field of osteoporosis. It could be interesting in some diseases, but not really in osteoporosis. And that's also why in the guideline for economic evaluation in osteoporosis, we recommended the use of mathematical model that allow to capture the long-term benefit and cost and consequences of healthcare intervention, and typically over a lifetime, over a long-term duration.
Thank you. And now Dr. Eschenbrenner is asking if you could elaborate on prediction models for measuring long-term effect on quality, for example, effects on intervention, the diagnostic, that targets specifically very early osteoporosis recognition.
Yes, I think we could, if we know what could be the long-term consequences of an early diagnosis, and if we could treat and maybe improve the bone of the patients, and if we know what could be the effect in terms of fractures, it's something that we could also model in an economic evaluation and see what could be the benefit, what could be the economic benefit of such intervention.
Thank you. So I think that before closing this webinar, I would like to take this opportunity to remind you that the WCO IOF SKO Congress is also a unique platform to get the latest scientific updates from our expert in the bold field. As just mentioned, Professor Hiligsmann will be presenting. So we encourage you to submit your abstract by February 20th. Here is a small teaser with a presentation of one of our experts, Professor Payman Haji, who will give a lecture on the management of premenopausal osteoporosis. We hope to have the great pleasure of welcoming you in Barcelona for an exciting and stimulating Congress. Now I would like to thank you all for your participation in this webinar. We will post the recording of this webinar on the IOF website, and you will receive the link to the recording by email tomorrow. You will also be prompted to fill in a survey immediately after this webinar. We would appreciate your input and comments. And if you have any questions, comments, please do not hesitate to send them at webinar@osteoporosis.foundation. Thanks again, Professor Hiligsmann, for this outstanding talk and great discussion. And goodbye to everyone.
Thank you.